Welcome, everyone, again. Thank you for joining us this evening. I think we could get started. Thanks again for joining for the Smilow Shares program on light chain or AL amyloidosis tonight. My name is Sabrina Browning. I am an assistant professor of medicine in the section of hematology here at Yale and a physician in the Smilow multiple myeloma and gammopathies program. And I'm honored to be joined tonight by my expert colleagues who all really serve critical roles in the multidisciplinary care of our patients with AL amyloid and have helped us to create a comprehensive discussion for you all tonight. So during our session, I will begin by providing some background on amyloidosis, and we'll then talk about soft tissue as well as gastrointestinal and liver involvement of AL amyloid. Dr. Ed Miller, who is an associate professor of medicine and radiology and serves as vice chief of cardiovascular medicine education, director of the Cardiology Fellowship Program, and director of the Clinical Nuclear Cardiology Laboratory here at Yale, will then give us a summary on cardiac AL amyloid. Dr. Randy Luciano will follow. Dr. Luciano is an associate professor of medicine in the section of nephrology and associate program director of the Nephrology Fellowship, and will discuss for us renal or kidney AL amyloid. And then Dr. Zivkovic is a professor in the Department of Neurology and is actually out of the country currently, but has kindly shared his expertise on nervous system involvement of AL amyloid. And then lastly, Dr. Terri Parker, an assistant professor of medicine in the section of hematology and assistant medical director at our Smilow Care Hospital North Haven location, where all of our amyloid patients receive their care, will speak to us about the treatment and management of AL amyloidosis. So our respective disclosures are all outlined here on this slide, and I encourage all of you to submit any questions that you may have in either the question and answer or the chat sections during our discussion. So to begin, amyloidosis is a group of diverse diseases that are all characterized by abnormal folding of proteins within the body. And these proteins then aggregate to form insoluble amyloid fibrils in what is referred to as a beta-pleated sheet conformation. And to date, there have been 36 different precursor proteins identified that can form amyloid fibrils and lead to amyloidosis. Amyloid fibrils then deposit extracellularly into organs and tissues, resulting in impaired function and progressive organ damage. And amyloid fibrils, which are depicted in the figure here on the right, have a unique appearance on electron microscopy, where they are rigid, non-branching fibrils and typically measure 8 to 12 nanometers in diameter. Additionally, the structure of amyloid fibrils leads to positive staining with Congo red dye in tissues and an apple green bifurengence that is observed when amyloid is viewed with polarized light microscopy. And this is illustrated in the bottom panel of the figure here on the right. Today, our focus is on light chain, or what was previously referred to as primary amyloidosis, where the amyloidogenic proteins are kappa or lambda light chains, which are produced from a clonal population of B cells located in the bone marrow. Lambda light chain is more common than kappa in AL amyloidosis, and in the majority of cases, there will be a clonal plasma cell population in the bone marrow. Although in AL amyloid, this clone can be quite small, and occasionally AL amyloidosis can occur in association with a lymphoma or a clonal lymphocyte population in the bone marrow. AL amyloidosis can be localized in nature, but more commonly will be systemic, where the amyloid fibrils deposit in several distinct tissues and organs, causing significant impairment in function. And we will discuss specific organ involvement with AL amyloid in more detail throughout the remainder of this talk. AL amyloid is a rare disorder with an incidence reported as 5 to 12 persons per million per year, and it can be quite aggressive, and therefore early diagnosis and treatment is really vital. Given the known delay in diagnosis with AL amyloidosis, the importance of early treatment to help prevent progressive organ disease, it's incredibly important to have a high level of suspicion for this disorder in patients with concerning symptoms, which again, we will review while covering the different organ systems, and notably in patients with a known monoclonal gammopathy. And this is really a driving factor in our group's goal to increase education and discussion about AL amyloidosis, including with all of you tonight. The diagnostic workup of AL amyloidosis will generally include, if not already completed, monoclonal gammopathy labs and a bone marrow biopsy. And regarding these gammopathy labs, it's important to obtain all those that I've listed here on this slide, given that, as mentioned, sometimes the monoclonal protein in AL amyloidosis can be quite low level, or there may be an abnormality only detected on the serum-free light chain assay. Amyloid should also then be documented on tissue biopsy, again using Congo red stain, and this can occur in the bone marrow on bone marrow biopsy, or with an abdominal fat pad aspirate, or less commonly a salivary gland biopsy. And the sensitivity of abdominal fat pad aspiration when combined with bone marrow evaluation has been reported to be as high as 85%. The figures here on the right show an abdominal fat pad aspirate sample from a patient of mine where Congo red positivity is seen on the top, and then green bifurcations displayed when exposed to polarized light microscopy. And lastly, a biopsy of a suspected involved organ may be required to confirm the diagnosis of AL amyloidosis if the previously discussed workup is not diagnostic. And as you recall, I mentioned there are up to 36 different amyloid proteins that have been identified, and therefore, after confirmation of the presence of amyloid in tissue, it's crucial to complete what we refer to as amyloid typing. Amyloid typing has been performed previously with immunohistochemistry, although this technique is thought to be unreliable in AL amyloidosis, as well as with immunofluorescence, such as in kidney biopsies and immunoelectron microscopy or immunogold. However, really our gold standard for amyloid typing is with liquid chromatography tandem mass spectrometry, which is a procedure where the amyloid deposits are microdissected and then proteins are sequenced by mass spec and compared with libraries of proteins for identification. And at our institution, we send out our specimens to the Mayo Clinic for amyloid typing by mass spec, again, as a gold standard. And importantly, accurate typing, as mentioned, of the amyloid protein is really essential to determine appropriate treatment for amyloidosis, given that different types of amyloidosis can have significantly differing treatment regimens. And this figure summarizes the pathogenesis of AL amyloidosis, which we have discussed. Again, an underlying B cell clone in the bone marrow produces excess or abundant serum-free light chains, which are abnormal and therefore misfold and form aggregates, which can be directly toxic to the organs and in particular the heart. And these aggregates then form amyloid fibrils, which then deposit into organs and tissues, some of which are depicted here and cause significant damage. And while this is a bit of a busy figure, it outlines the tissues and organs that can be affected by AL amyloidosis. So again, after confirmation of amyloid by Congo red in tissue, followed by typing, it's then important to determine organ involvement. And we will discuss several of these in more detail as mentioned. Patients with AL amyloid can also present with non-specific symptoms, including fatigue and unintentional weight loss, and can have bleeding or easy bruising for a number of reasons, including acquired deficiency in factor 10, which is a clotting protein that can be absorbed and eliminated by amyloid fibrils. Importantly, AL amyloidosis does not affect the brain and the central nervous system. Moving on to soft tissue involvement of amyloid, this affects approximately 10% of our patients. Macroglossia or enlarged tongue and periorbital purpura or bruising around the eyes are classic features of AL amyloidosis, but really are found in only a small proportion of our patients. On exam, macroglossia may present with dental indentations on the lower tongue, which we refer to as scalloping, as well as a firm or stiff tongue on palpation. And the figure here on the right provides an example of these findings. Macroglossia can lead to a variety of things, including obstructive sleep apnea, altered taste with difficulty eating and swallowing, and dry mouth. And unfortunately, there are no specific therapies for macroglossia outside of monitoring for organ response as a result of administration of systemic antiplasma cell therapy, which we'll hear more about later from Dr. Parker, although some patients with severe macroglossia may need a feeding tube for adequate nutritional intake. And the periorbital purpura that you see here on the right results from vascular fragility due to amyloid deposition in the soft tissues and vessels that are located around the eyes. Patients can also get things like nail abnormalities, joint pain and swelling as a result of amyloid deposition in the joints, as well as claudication or pain with ambulation or use in the jaw, buttocks, or calf. And this is due to amyloid deposition in the small vessels. Amyloid deposition in the GI tract can result in several symptoms, including nausea, vomiting, dyspepsia or indigestion, abdominal bloating or pain, diarrhea, constipation, malabsorption, or symptoms of gastroparesis. And it can sometimes be difficult or challenging to differentiate these findings from those we see where amyloid infiltrates the autonomic nervous system that controls the bowel. Patients with GI amyloid can also have complications that can include GI bleeds, obstructions, intestinal perforation, or gastric outflow obstruction. And GI amyloid can also be localized in nature, and therefore it is important for patients who have Congo red positivity on a GI biopsy to complete a comprehensive evaluation to determine the presence of amyloid involvement in other organs, which would indicate systemic disease. And close collaboration with our GI colleagues is very important, both for monitoring and symptom management for these patients. And the figure here on the right, included on the slide, shows amyloid in the stomach and small intestines as seen in biopsy during an endoscopic, upper endoscopic procedure. And then lastly, liver involvement of AL amyloid generally presents with enlargement of the liver or an increase in alkaline phosphatase level. Liver involvement is seen actually more commonly with kappa light chain amyloid and is often seen concomitant with kidney involvement. The presence of symptomatic liver involvement or synthetic liver dysfunction or liver failure is quite uncommon. And so when this is seen, it likely indicates more advanced or late stage disease in regards to the amyloid. Given the potential for other disorders to cause enlarged liver, hepatomegaly, and abnormal liver enzymes, liver biopsy is sometimes needed for a definitive diagnosis. And again, incorporating our hepatology colleagues into the multidisciplinary care of our patients with AL amyloid is definitely very, very beneficial. So I will stop sharing my screen and invite Dr. Miller to discuss with us about cardiac amyloid.
All right, thanks, Sabrina. Nice to see virtually everyone. Happy to be here tonight to talk about cardiac amyloidosis. How does this look? Does this look okay, Sabrina? All right. So again, I focus on cardiac amyloidosis, and I'm going to talk about AL amyloidosis, but I'm also going to talk on the other type of cardiac amyloidosis as well, called TTR amyloid, a bit, because I frequently get questions about both types of amyloidosis. So I don't want to gross people out on the call who may not have a medical background, but I think this is a really illustrative slide. So with what happens in amyloidosis is, as Dr. Browning was mentioning, is that you have amyloid fibers that deposit in organs, and it causes those organs not to work well. And it makes those organs really stiff. And what we're seeing here is a heart of a patient who underwent a heart transplant. So this is the heart that's been taken out of the patient, and they've received a new heart and they're doing very well. But when you take a heart out of somebody, what should happen after the blood goes out of it is that it should collapse on itself because there's nothing to hold it open anymore. What you can see here in these, you can see chambers that are normally filled with blood that are held open by these amyloid fibers that are deposited in between the cells of the heart. And so this really shows you the stiffness and the architectural change that patients who have amyloidosis undergo. And when the surgeons put I think this is a couple liter bottle of fluid on top of the heart, you see it doesn't collapse, which is again is showing how the physical changes that are occurring when amyloid deposits in the heart. It doesn't really matter what type of amyloid it is, the same type of changes generally occur. As Dr. Browning was mentioning, it's really important, particularly in the heart, to understand the type of amyloidosis that one might have. And I always caution my patients not to Google cardiac amyloidosis or look it up, because it's such a complex disease, and there are a lot of subtleties to it, and one can quickly become both confused and disturbed by what one reads on the internet and according to Dr. Google. But in general, in the heart, there are two types of amyloidosis that occur. The first is the type that we're focusing on tonight, which is light chain amyloidosis from the bone marrow cancer type process Dr. Browning was describing. In that disease, light chains or parts of antibodies deposit in the heart and other organs. But it's also important to realize that much more commonly, the type of amyloidosis that people will have, that I see and will be seen by cardiologists, is from a completely different disease called transthyretin or TTR amyloidosis. So even though they're both called cardiac amyloidosis, they're much different in how they're treated, and what their prognosis is. And so we have to differentiate those two types of amyloid if we're going to treat patients effectively. So here's a nice graphical cartoon of what light chain amyloidosis, what happens. As Dr. Browning mentioned, there's a problem with cells in the bone marrow where plasma cells, or these cells that produce antibodies, kick out proteins. Those proteins circulate through our blood, and the proteins that are circulating are called light chains. And those light chains stop folding correctly. When they stop folding correctly, they come out of solution in our blood and then deposit into different organs. When they deposit, they organize together to make these sheets of sticky material that cause the organs not to work well. And those are called amyloid fibrils. And they can deposit in organs such as the heart or other tissues. Instead of having the protein come from the bone marrow, in the other type of cardiac amyloidosis, TTR, a protein's coming out of the liver. It's a protein that we all have all around that circulate through our bodies throughout our entire life, called TTR. And it circulates, and as we get older, or if we have genetic mutations, again, amyloid fibers can form, but those amyloid fibers are from a completely different protein and a completely different process. They also cause similar heart problems. So if you're looking for cardiac amyloidosis, you have to understand whether somebody has systemic amyloidosis or amyloidosis that involves other organs besides the heart. Personally, I think there's no other organ besides the heart. Dr. Luciano might disagree, but nonetheless, cardiac amyloidosis is something that we can usually look at to help figure out whether cardiac amyloidosis may be present by looking at what we call non-invasive testing or imaging of the heart. So this can include things like an echocardiogram, an ultrasound of the heart. It can look at MRI scans of the heart or other nuclear imaging studies that help us to differentiate and look for amyloidosis that's affecting the heart. Patients with amyloidosis of the heart, whether it's of TTR type or AL type, have some common features. The heart gets thick, or what we call ventricular hypertrophy. And when the heart gets thick, it doesn't relax well, what we call diastolic dysfunction. And so the heart is restricted in its movement. We get problems with the EKG, and we can get arrhythmias. Most patients present to my clinic with symptoms of what we call heart failure, which means, generally speaking, edema or swelling that involves the legs and into the lungs. For a number of different reasons, people can get lightheaded and have low blood pressures when they stand up. That's called orthostasis. As Dr. Browning was alluding to, people can get the classic anginal symptoms or chest pain and have trouble with passing out, what's called syncope. But the prognosis and the treatment for patients is very different. So AL cardiac involvement is something that I talk to the people on this call very often about as an emergency. Meaning we have to see if it's present and treat it aggressively and early in order to prevent further progression. TTR amyloid, on the other hand, takes a much slower course. And even if we don't treat it, the survival can be years and decades. When we're talking about amyloidosis, we can, in the heart, we can stage people, meaning we can tell them how severe their amyloidosis is. And we can use things like measurements of common blood tests, such as troponin, or another test called a BNP test. And those look at things related to cardiac function. And generally speaking, the more abnormal those things are, the worse the prognosis might be for somebody. And we treat patients more aggressively or in different ways based on those staging systems. Because I get a lot of questions about TTR, I'm going to talk about some of the aspects of that as well. So it has similar features in how it presents to AL amyloidosis of the heart, but there are some specifically different features, in particular, those relating to neuropathy, as Dr. Zivkovic will talk about, as well as things like carpal tunnel syndrome and that orthostatic low blood pressure syndrome, what we call autonomic dysfunction. These things, including aspects of age, sex, weight, and race, will cause us to screen different types of patients for different types of amyloid. I should also mention that with respect to TTR amyloid, there is a genetic variant of this disorder where it's passed down from parent to child in many cases. I should also mention that AL amyloidosis, as opposed to TTR amyloidosis, does not have a genetic component to it. So people always ask me, well, my brother had AL amyloidosis, or my sister or uncle, am I likely to get it? The answer to that is no. With regards to amyloidosis, should we be screening patients with heart failure for amyloidosis? In particular for the TTR type, we think so, because a lot of patients have TTR amyloidosis as they get older and in various conditions in various racial and ethnic groups. So I'll finish with some slides on the treatment for cardiac amyloidosis, not in the chemotherapy, but the simple stuff that I do, not the complex stuff that oncologists do. So some general principles about cardiac involvement. We want to take away people's fluid, meaning their edema, their swelling in their legs and their ankles and in their lungs. We want to keep them in normal rhythm. And in many cases, because patients have been told they have a heart problem, they've been put on medications that are commonly used for heart problems that actually make cardiac amyloidosis worse. So things like medications that are commonly used for heart failure, things like beta blockers or other medications that don't have a benefit in patients with amyloidosis and make them feel much worse. In patients who have low blood pressure, and Dr. Luciano will probably talk a little bit about this, we can use medications that support the blood pressure, such as mitadrine. We can use blood thinners because of a risk of stroke, and in some cases, put in things like a defibrillator to protect from arrhythmias. I'll say one slide on TTR therapies, which have come a tremendous way since 2019. There are many different options in this space, including pill forms and injection forms to reduce the amyloid burden that's circulating or prevent it from depositing. We're excited to be part of a gene editing study, which will be enrolling for patients at risk for TTR amyloidosis as well. Lastly, we are involved in a number of multi-center trials here at Yale, include for TTR amyloidosis and other amyloidosis, including one focused on screening minority populations for cardiac amyloidosis because of a genetic predisposition in patients of West African heritage. If anybody's interested, please reach out to me, and I'm happy to discuss this further. So thanks for the opportunity to talk, and I'm looking forward to further discussion and answering questions. This is all my team and collaborators around the country as well as at Yale. So thank you very much.
Thank you, Dr. Miller. And Dr. Luciano, if you're all set, you can proceed with your discussion.
Sorry, just having an issue with the sharing. I apologize.
I would just add while we're waiting for the next presentation, thank you for those who have submitted questions in the Q&A in the chat portion. We will try to save the questions for the question and answer session at the end, but please continue to submit those questions.
Okay, sorry about that. Is that visible?
It is, it's just in presenter view.
Oh, okay. I will get this. Still the same? Is that better?
Looks
Okay.
great. Yeah.
Okay, sorry, I was dealing with two screens and I'm not used to this. So at this computer. Okay, so hi, thank you, Sabrina, Dr. Browning, for inviting me to talk about amyloidosis in the kidney. So I am a kidney doctor, and I will talk about what we call renal amyloidosis or amyloidosis in the kidney. In the kidney world, we have a lot of different terms for the kidney. So when you hear renal, it's synonymous with the kidney for the most part. And there's some other terms which we'll go over. So if you don't have a medical background, I'm going to go into the kidney, what it is and why it becomes diseased and how it becomes diseased in amyloidosis. So kidneys are organs that filter and clean the blood. Most people have two kidneys that kind of sit in our back. They're kind of higher up than most of us think, just a little bit below the posterior rib cage. And what they do is at any given time, they're receiving about 25% of the total blood volume, and they're filtering this blood. In the kidney, there are these small little filters called glomeruli, which are these beautiful collection of cells, collagen, and it's the interface between the blood and the urine, more or less. So as blood is filtered, what happens is blood passes through more or less these filtering units and it creates urine. Function of the kidney can be checked by looking at blood work. In blood work, we check something called the creatinine. Creatinine will tell us how well the kidneys are doing their job, which is cleaning the blood. Creatinine is checked at, with basic metabolic with a basic metabolic panel. It's something that your provider would check with routine blood work, for example, for a physical. This creatinine level can tell us how well the kidney is doing its job or working. Now, the other thing which we look at is we look to see whether or not there's anything in the urine that should not be there. Two of the more revealing things could be blood in the urine and or protein in the urine. If you find either, it could tell you that there's damage to the kidney, which is causing blood and or protein to leak from the blood into the urinary space. And we'll get that into a second. We'll get into how that happens in a second. Now, many different diseases can cause damage to the kidneys, the most common being diabetes. High blood pressure is probably the second most common disease process that can affect the kidneys. And then there's a lot of other things, including infections, cancers, certain medications can harm or damage the kidney, leading to impaired kidney function. So again, the kidney is a filter. Blood is filtered through the glomerulus. And the byproduct of this filtration more or less is urine. That's a very simplistic way of looking at the kidney. And if we look on the right-hand side of the screen here, we have a very simplistic view of this filter. And it's important to kind of understand this process because it will give us clues as to how a specific disease is affecting kidney function. And it'll also give us clues as to how we can treat it, but more importantly, what we expect in terms of recovery of kidney and the kidney function. So blood is filtered through this filter, which is called the glomerular basement membrane, which is essentially a collection of collagen. In so doing, everything that our body doesn't need kind of passes through. We have the passage of all these toxins that go through this membrane. And we also have passage of certain electrolytes, sodium, potassium, magnesium, calcium, which then fall into these collection tubules demonstrated right here. And that's essentially the beginnings of the byproduct of filtration, which more or less becomes urine that we excrete. As this liquid travels through these tubes in the kidney, we have reabsorption of certain substances that allows our kidney to modulate not only the electrolytes in our body, but also the amount of fluid. This filter is very selective. Blood cells will stay in the blood, and protein should also stay in the blood. Protein should not cross this glomerular basement membrane and actually go into the urine. So if we see blood and or protein in the urine, it could tell us that this membrane or this filter is in some way damaged. Albumin is one of the most abundant proteins in the body. It exists in the blood vessels. We can measure that with routine blood tests, or more or less routine blood tests. And the presence of albumin, which we'll get into in a second, is very important for the blood itself. If albumin, a protein, leaks into the urine, we can pick that up in urinary tests, and it can tell us that there's something wrong with the membrane, because albumin normally should not leak across the membrane into the urine. If albumin does leak across the membrane and goes into the urine, it tells us that there's some defect in the membrane, and that defect can be varied. Okay, so how do we notice kidney damage? Again, we notice this in two ways. If the kidney is not filtering well, we can see that the creatinine level will be significantly increased. Creatinine is a substance made by muscle that circulates in the blood, and it's filtered through this membrane and excreted in the urine. Now, if the membrane is not working effectively, what will happen is the creatinine will increase because the kidney is unable to filter all of that creatinine out of the body, which is a byproduct, or which is a surrogate for filtration in general. So a higher creatinine indicates that the kidney is not filtering well. Now, the other way to see whether or not the kidney is working well is to look at albumin in the urine. If we start seeing albumin in the urine, it tells us that this membrane has some damage, and it's leaking, and it's allowing the leaking of this albumin from the blood into the urine. Now, filtration may not be impaired if albumin is leaking into the urine. So you can have a normal filtering kidney with the leakage of albumin. And there's a lot of subtleties as to what causes one versus the other, but the presence of either indicates, or both, indicate that the kidney has sustained some damage. Now, taking a step back, because this is going to be important when we talk about amyloidosis in the kidney. So what is the importance of this albumin, and what happens when it leaks out of blood vessels and is excreted in the urine? Now, albumin is a protein that exists in the blood vessels. This is an example of a blood vessel with red blood cells and albumin. There's other components there too, but these are the two substances we're going to focus on. The cellular component, the red blood cells, and the protein, the albumin. So one of the functions of albumin is to actually serve as a substance that allows the fluid portion of blood to actually stay in the vessels itself. So if albumin is present at a relatively normal or high level in the blood cells, it's going to allow that fluid component of blood is fluid plus red blood cells, to actually stay in the blood vessels. Now, if albumin is decreased in the blood vessels, and one way for this to occur is through the leakage of protein of albumin from the blood vessel into the urine, and we can lose albumin that way. What's going to happen is the blood vessels, or the blood vessels cannot hold on to that liquid component. The albumin is there to kind of, in a sense, keep that liquid in the blood vessels. If albumin is gone, what happens is the liquid or aqueous component of the blood can then leak out of the blood vessels and be deposited elsewhere in the body. And this is often seen with edema. So that fluid will leave the blood vessels and kind of sit elsewhere in the body. One place where we can definitely see this on a physical exam is in the lower extremities. And this is just a picture of edema in the lower extremities. So normally when you push it on your foot, you may notice a little indentation, but in patients who have a very low amount of albumin in the blood, who've lost albumin in the urine, patients that I see in my kidney or nephrology clinic, they will have a significant amount of edema. And if you push in on lower extremities or even other parts of the body, you'll get a pretty significant indentation that will last for a significant amount of time. This indicates that that fluid, which is normally in the blood vessels, has leaked elsewhere. And one of the culprits can be the loss of this albumin in the urine. So as I stated, there's damage to the glomerular basement membrane. So if you remember back to Dr. Browning and Dr. Miller, they talked about these abnormally folded proteins. So these abnormally folded proteins, this amyloid protein, or this amyloid substance, actually gets filtered through the kidney, and it can actually deposit in the membrane itself. When it deposits in the glomerular basement membrane, it actually disrupts the integrity of this membrane. When that membrane integrity is compromised, protein or albumin can no longer stay in the blood vessel. It actually leaks or seeps through into the urinary space, and you can lose a lot of albumin over a given period of time. At any given time, the kidney's filtering 25% of the total blood volume. It filters blood at a rate of roughly 150 mils per minute. So you can definitely lose a lot of albumin in a very short amount of time. And this can actually lead to pretty explosive, what we call protein or albuminuria, and the presence of, and subsequently the development of edema in a very short amount of time. So this is actually a sample of a kidney filter, or this glomerulus. On the left-hand side, this is a normal filter. And I don't expect anybody to actually understand these pictures, but hopefully you can see the striking difference between the two. So this right here is a normal filter. It has a collection of membranes and cells that allow for blood to pass through and create urine, more or less. Now, on the right-hand side, you can see that these are the two exact same structures from two different patients, of course. One is a very normal looking one, and one is a very abnormal looking one. So I don't expect anyone to know anything about pathology, but hopefully you can appreciate the difference between these two figures. On the left-hand side, you have a very normal looking one. On the right-hand side, you have a very abnormal looking one. And hopefully the abnormality you can appreciate is this very intense pink substance that is there. That pink substance is albumin, which has basically flooded this whole filter, and in so doing disrupts the integrity of the filter and causes a spillage of protein or albumin into the urine. When we kind of blow this up in a larger scale, so we use a special microscope called the electron microscope, we have a normal filter here, and this is that membrane. On one side you have blood, on the other side you have the urinary space. Blood crosses this way. Blood is filtered this way, and you have the production of urine here. Now, this filter is a very normal looking filter on this side. This is a filter that is completely filled with this amyloid protein. And if you blow this up, you see these small little fibrils that are just jammed into this filter space. When that happens, it disrupts the integrity of this filter. These amyloid proteins allow for the leakage of albumin across the filter from the blood side into the urine side. And this is essentially what we're dealing with. This is a beautiful picture of these abnormally folded proteins that's basically leading to pure disease in the kidney itself. And that's the main problem that's occurring in kidney disease, in amyloid related kidney disease. There's some other minor disease processes that can occur, but this is perhaps the most significant one and the one that causes the most distress with patients. So how do we diagnose this? So if we know that the creatinine is abnormal, if we know that there's protein in the urine, we then want to figure out whether or not there's kidney involvement. Sometimes we're actually seeing patients before we identify amyloid. Oftentimes I see patients who have new onset swelling or edema and or new onset protein, and we quite haven't figured out that they have amyloid yet. So in those patients, or in patients who have amyloid and we want to see if there's kidney involvement, we can do a kidney biopsy. A kidney biopsy is a minimally invasive procedure whereby you use an ultrasound and a biopsy needle device to take 2 to 3 small samples from the kidney. The kidneys sit in the back. They're actually somewhat close to the surface, only about 5 to 10 centimeters deep. You do this under ultrasound guidance. This is actually the needle going into the, abutting the kidney. You just press a little button on this device and the needle injects into the kidney and you pull out. The whole process itself takes roughly 5 to 10 minutes, with the majority of that being set up. And what this yields is these small little kidney pieces. This piece is less than 1 inch long, and although this is blown up, it's about the thickness of a piece of dental floss. You take 2 or 3 of these samples, you send them to pathology, and they process them with special stains, immunofluorescence, and electron microscopy, which gives us the images that I just presented before of these filters that are either normal or have some form of disease in them. We can easily pick amyloid up in a sample that is that small. And again, this sample is very small, and it'll give us roughly 20 to 30 filters. And if amyloid's involved in the kidney, all of those filters will have evidence of amyloid in them. Again, this is another picture of what we obtain. You have this filter with this very abnormal protein in it, or this very intense amyloid protein in it. Now, we're talking about AL amyloid, but as Dr. Miller talked, there are other forms of amyloid that can affect different organs. The kidneys, though, different. We have different forms of amyloid, which I'm not going to get into. We have an infection-mediated amyloid, and then rarer forms of amyloid that are due to abnormally folded proteins. And we also have hereditary forms of amyloid that affect the kidney. But perhaps the most significant one is AL amyloidosis, the one that Dr. Browning and Dr. Miller were both talking about, and the one we're focusing on tonight. Upwards of, depending on what study you see, anywhere between 75 to 85% of patients with amyloidosis may have some form of kidney involvement. Now, kidney involvement can be varied. You can have minor proteinuria or protein or albumin in the urine. You can have massive amounts of albumin in the urine. To put things in perspective, the normal amount of albumin in urine in a patient who has normal kidney function with no significant disease is roughly 30 milligrams. Which is a very, very small amount. Now, in patients who have amyloidosis, this can go upwards of 20,000 milligrams, or 20 grams of protein. And that's a tremendous amount of protein that's spilling from the blood into the urine. A patient can be losing a lot of protein in patients who have very severe amyloid involvement in the kidneys. Again, it can also be minor, but in a lot of cases, in those who present, they're presenting with very severe forms of amyloid in the kidney with a lot of protein in the urine. So what happens when the kidney loses a tremendous amount of protein? Well, the first thing, or the most noticeable thing, is that the patient will develop edema or swelling, as I had previously mentioned. Other things that happen is the kidney can filter less effectively, and this can lead to an elevation in the creatinine. So this protein there can inhibit the ability of the kidney to get rid of all the toxins. And in so doing, your creatinine will be higher, and the patient may develop some degree of sickness from that. Usually the edema comes on first, and you notice that before the kidney starts getting into significant, the kidney function becomes significantly impaired. Your cholesterol numbers can also increase. As protein is being lost into the urine, the liver will compensate for that and try to build up the pressure in the blood, so it'll actually increase cholesterol. And patients with normal cholesterol easily can get cholesterol numbers into the 300 to 400 range in diseases where you're losing a significant amount of protein. When you're also losing protein, you not only lose albumin, you can also lose other proteins that have other functions in the body. And one set of proteins that you can lose are proteins that are involved in the clotting cascade. Specifically, you lose proteins that help the body prevent clotting. So if that happens, you're shifting the body from a neutral clotting state, because you're losing proteins that prevent clotting, to a pro-clotting phase, and patients are at a higher risk of clotting. This is somewhat correlated with the amount of protein that's lost, and patients who are losing more protein have a higher risk of forming blood clots. And also you can lose proteins that are responsible for infection or controlling infection, and you have a slightly increased risk of infection when you lose a significant amount of protein. So lastly, how do we treat amyloid in the kidney? So first, to actually treat the disease itself, which I'm not going to get into, you actually treat the underlying amyloid disease. And I know there'll be some talk about that a little later on. Rarely am I doing this myself. Actually, I'm never doing it myself. I'm usually doing it in conjunction with an oncologist. And we're coming up with a therapy plan that is safe for the patient and will not in any way harm or further disrupt the function of the kidney. But mostly when this happens, the disease is relatively systemic or systemic, and therefore we're referring to oncology, and the oncologist is coming up with a treatment plan and treating the patient. We do, however, want to treat some of the adjunct processes that occur. So with the swelling, what you want to do is treat with diuretics. Depending on the degree of swelling and the blood pressure, you may also want to add medicines that can help modulate urine flow and decrease protein. That becomes somewhat tricky because in a lot of amyloid patients, blood pressure can become very low due to several things: autonomic or nervous system dysfunction, also the loss of what we call this oncotic pressure, among other things. And if there's cardiac involvement, you would not necessarily want to use these medications. But in patients who have low levels of protein loss and or isolated kidney function, we will try to use some of these medications that can prevent the loss of protein in the urine by modulating flow to the kidney with what we call ACE inhibitors, ARBs, or mineralocorticoid receptor antagonists. As far as acute kidney injury, so when the kidney is losing a lot of protein and we're trying to diurese, the kidney is very prone to injury. So we want to be very mindful of blood pressure and not push the blood pressure too low, which can become somewhat difficult when you're trying to diurese or get fluid off of these patients. And you also want to make sure you're not providing the patient with other medications that can adversely affect kidney function, such as your NSAIDs, which are ibuprofen, Advil, Motrin, or Aleve. And you want to be careful of herbal supplements, which can have significant impact on kidney function. With increased cholesterol, you want to place the patients on statins. Amyloid can take a while to treat, and the kidney problem itself can actually take much longer than treating the underlying amyloid itself, because it takes a while for the kidney to repair itself. So even if you treat amyloid, you may still be losing protein for a while after you've successfully treated amyloid with certain blood parameters being achieved. So you probably want to put these patients on statins, assuming there's no other contraindication, to help lower the cholesterol. To address the increased risk of blood clots, we put patients on aspirin if they have a minimal amount of protein loss, or stronger anticoagulants if they have more significant protein loss. Blood clots are significant, and they can lead to significant morbidity, including pulmonary embolus or stroke in certain patients. And for increased risk of infection, we actually don't give any antibiotic prophylaxis specifically, but we recommend vaccinations before starting treatment, avoidance of people who are ill around the patient, and just vigilance going forward. And I believe that is it. And I will then turn it over to Dr. Browning.
Thank you very much. And we're now going to share a video from Dr. Zivkovic. Eliza, you're muted. We just have to unmute.
I'm Sasha Zivkovic. I'm a neuromuscular neurologist, and I will be talking to you about nerves and light chain amyloidosis. Amyloidosis can be associated with peripheral neuropathy. So what is neuropathy? The term itself refers to various conditions that affect the function of peripheral nerves that send and receive the signals between the brain and the spinal cord in other organs and parts of the body. Peripheral nerves control the function of muscles and different types of sensations. Typical symptoms of neuropathy include numbness or lack of sensation, and different types of abnormal sensations like tingling. Some patients may also experience neuropathic pain, loss of strength, or loss of coordination. Symptoms of neuropathy are often worse, or they start in the feet, where we find the farthest nerve endings, which are farthest from the central nervous system. In general population, 2 to 3% of all people have neuropathy, and it becomes much more common as we age. It has been estimated that around 8 to 10% of people after the age of 55 will develop neuropathy. In the Western world, the most common cause of neuropathy is diabetes, which affects more than half of all diabetics. 10% of all patients with neuropathy with unknown cause will also have monoclonal protein in their blood, and this condition is usually not associated with any hematologic disorders and is then caused monoclonal gammopathy of unknown significance. In patients with light chain amyloidosis, it has been estimated that 1/3 to 1/7 of all patients with light chain amyloidosis will have peripheral neuropathy. So why do patients with light chain amyloidosis get neuropathy? Neuropathy may develop as a result of deposition of amyloid in peripheral nerves. We can also have deposition of amyloid in connective tissue and muscle tendons that may compress the nerves and lead to nerve entrapment. Most common is carpal tunnel syndrome, where the nerve is entrapped at the wrist, leading to hand numbness, weakness, and discomfort. Some of the medications can also cause neuropathy. Patients with light chain and diabetes may develop diabetic neuropathy, and we can also have neuropathies associated with different types of nutritional deficiencies and with different type of autoimmune disorders. Neuropathy may also be the first sign of light chain amyloidosis, or it can present later in the course of disease. Some of the early signs of neuropathy in light chain amyloidosis include loss of sensation, which is present in 5 out of 6 patients with amyloid neuropathy early on. Some of the patients will develop loss of strength and weakness, and some may display abnormal function of autonomic nervous system, manifesting with various symptoms like vomiting, diarrhea, constipation, partial hypotension, and this is a condition when the blood pressure drops suddenly upon the change of position, typically when patients stand up. Patients may also have decreased sweating, and overall amyloid neuropathies are often painful, but it can be painless as well, and sometimes they can present with dysautonomia, but dysautonomia is not present in every patient with amyloid neuropathy. So how is neuropathy diagnosed in amyloid patients? Evaluation starts with neurologic consultation with different types of lab tests that look at alternative causes of neuropathy. And many patients will also undergo electromyography with nerve conduction studies. And we can also pursue nerve and muscle biopsy to look for the position of amyloid in peripheral nerves and muscle. As the signs and symptoms of amyloid neuropathy are not specific for light chain amyloidosis, diagnosis is often delayed up to 2.5 years or even longer. Once patient is diagnosed with neuropathy, we can try to treat the symptoms of neuropathy, but the Priority is the treatment of the underlying disease of light chain amyloidosis. Treatment of light chain amyloidosis may also lead to improvement of neuropathy. And the supportive and symptomatic treatment of neuropathy may include physical and occupational therapy, treatment of neuropathic pain, and removing other factors that can potentially worsen the neuropathy. To summarize everything, so peripheral nerves are often affected in light chain amyloidosis. And peripheral neuropathy may be the first sign of amyloid deposition. Some of signs and symptoms of neuropathy include loss of sensation, lack of coordination and unsteadiness, weakness, neuropathic pain, orthostatic hypotension, abnormal sweating, and loss of bowel control. You can also find a lot of helpful information on the internet. At the website of Amyloidosis Support Group, you can find a wealth of information on different types of amyloidosis, all kinds of aspects of amyloidosis that can affect your daily lives, and all kinds of information on amyloid neuropathy. At the website of National Institute of Health, you can look at the web page on peripheral neuropathy that will provide you on information. What is peripheral neuropathy? What kind of symptoms are associated with neuropathy, and what can be done about them? And on YouTube, you can find a very helpful video, what to expect during electrodiagnostic testing. Once again, I want to thank you for your attention, and I want to thank the organizers for inviting me to present you this information on nerves and amyloidosis. Thank you.
Okay. And last, we are going to be talking about the treatment of AL amyloidosis. So when we talk about treatment, our goal is really to treat the underlying plasma cell disorder with the goals of decreasing amyloid production, limiting further organ damage, and allowing for regression of tissue amyloid deposits. Hopefully, you have all heard tonight that management is truly multidisciplinary across several disciplines. All patients with systemic AL amyloidosis require treatment at the time of diagnosis. However, treatment is not necessary with localized forms. Therefore, as previously mentioned, it's important to determine if a patient has localized or systemic AL amyloidosis. As AL amyloidosis is a rare disease, we previously did not have published treatment guidelines until 2022. And then the European Hematology Association, in conjunction with the International Society of Amyloidosis, published a set of guidelines. As part of these guidelines, the first question was whether or not an individual was eligible for autologous stem cell transplant. Eligibility is key, as careful patient selection will avoid early mortality, or what we would call increased risk. Overall, the hematological overall response rate for autologous stem cell transplant in AL amyloidosis has been shown to be about 84%. And so as part of this checklist, they have different inclusion and exclusion criteria and evaluation for, again, autologous stem cell transplant. These include items such as age, performance status, which is how functional an individual is, blood pressure, evaluation of their heart, liver, kidney, and respiratory function. Some items that would exclude patients from proceeding to autologous stem cell transplant include refractory orthostatic hypotension, meaning low blood pressure, refractory arrhythmias or abnormal heart rhythms, decompensated heart failure, refractory pleural effusions, which is fluid in the lung, or an increased risk of bleeding. So if we evaluate our patient and we determine that they would be eligible for an autologous stem cell transplant, the next step is often induction chemotherapy or chemoimmunotherapy, typically giving 2 to 4 cycles. The current recommendation is for a combination of daratumumab, which is a CD38 monoclonal antibody, in conjunction with cyclophosphamide, bortezomib, and dexamethasone, often abbreviated as CyBOR-D. Typically, induction therapy is recommended for any individual who has a bone marrow plasmacytosis, meaning involvement of their marrow by over 10% plasma cells. However, more often than not, we are proceeding with 2 to 4 cycles of induction prior to autologous stem cell transplant. As if patients obtain a hematological complete response with induction, autologous stem cell transplant may be deferred. By starting induction therapy, it also allows us a faster time to potential organ response as well. If a patient has an advanced single organ dysfunction due to AL amyloidosis, it is possible to perform a solid organ transplantation, such as a heart or kidney transplant prior to autologous stem cell transplant. For those patients undergoing autologous stem cell transplant, melphalan, which is a type of chemotherapy, is used as our conditioning regimen. This can be dose reduced if an individual does have renal dysfunction. After autologous stem cell transplant, we would assess the response. And if an individual has achieved a very good partial response, then they would go on to observation. There's currently no maintenance therapy for AL amyloidosis. However, if an individual has a concomitant multiple myeloma diagnosis, then maintenance therapy may be indicated. So for those not familiar with autologous stem cell transplant, we use a patient's own stem cells. Mobilization of those stem cells is achieved using a subcutaneous injection called a granulocyte colony stimulating factor. These cells are then leukapheresed off. During this period, fluid shifts can occur, so it's really important that we monitor a patient's fluid status closely. These stem cells can be frozen for use at a later date or used almost immediately. If patients are proceeding directly to autologous stem cell transplant, they would then be given high-dose chemotherapy, which is where the melphalan comes into play, prior to having their own stem cells reinfused. Now, unfortunately, not all of our patients are considered to be transplant eligible. Again, a lot of this is due to organ dysfunction, advanced age, patient preference. And so if an individual is not transplant eligible, our next step is to really assess for any contraindications to bortezomib, which is a chemotherapeutic agent, also known as Velcade. The most common reason for our patients to have a contraindication to bortezomib is peripheral neuropathy, which, as just mentioned, can be seen in up to 15% of our patients. And this is because one of the side effects of bortezomib can be peripheral neuropathy. If bortezomib is not a contraindication, then we look at our staging. And for stage 1 to 3A, and the staging system is the European Modified Mayo 2004 staging system, we would use what was mentioned previously, a combination of daratumumab, a CD38 monoclonal antibody, with cyclophosphamide, bortezomib, which is Velcade, and dexamethasone. For those patients who are at stage 3B, and again, our staging is largely based on cardiac involvement, utilizing a proBNP and troponin. We would also use the combination of daratumumab, cyclophosphamide, bortezomib, and dexamethasone. However, we would dose adjust. Specifically, the dose of dexamethasone would be adjusted down to 20 milligrams maximum, and oftentimes we have to go lower. And the dose of bortezomib would be dose adjusted down to the lowest dose possible, which is 0.7 mg per meter squared, and that can always be dose escalated depending on tolerability. So you're in an area where daratumumab is not available, which could be parts of the world not here in the United States. Then we could utilize induction regimens such as cyclophosphamide, bortezomib, dexamethasone without the dara, or bortezomib, melphalan, dexamethasone. So we mentioned the combination of daratumumab, cyclophosphamide, bortezomib, and dexamethasone. So this is a relatively recent recommendation, and it comes from a clinical trial that's often called the Andromeda trial. This was published in the New England Journal of Medicine in 2001. This was a randomized phase 3 trial in treatment-naive patients, so individuals who have never seen therapy. There was a total of 388 patients who were randomized to receive either the combination of Cytoxan, bortezomib, dexamethasone versus daratumumab, Cytoxan, bortezomib, dexamethasone for 6 months, followed by 18 months of daratumumab maintenance. The primary endpoint of this trial was the hematological complete response rates. And what they showed was that there were higher rates of a hematological complete response at 53.3% in those individuals in the daratumumab group compared to 18.1%. And they had the median time to hematological CR, complete response, of 60 days. They also showed cardiac and renal responses were improved in the individuals who received daratumumab at the 6-month mark, 41.5 versus 22.2%, and 53% versus 23.9%. The daratumumab group was favored across all cytogenetic subgroups, and this trial led to daratumumab in combination with Cyber-D becoming the first drug approved by the FDA in February of 2021 for AL amyloidosis. So there's a few caveats here to induction therapy. One is if an individual has an IgM-producing clone. This accounts or can be seen in up to 5% of all AL amyloidosis patients. And in that case, the current guidelines recommend the use of rituximab and bendamustine, which is a chemotherapeutic agent and an immunomodulator, anti-CD20 monoclonal antibody. The hematological response rates with this combination is 60%. A few cytogenetic considerations. If an individual has a translocation 1114, which is the most common cytogenetic abnormality we see in AL amyloidosis patients, with a rate of occurrence between 40 and 60%, this translocation has been associated with a lower response rate and poorer survival in individuals who are treated with Cyber-D. However, this risk can be overcome with the additions of daratumumab and or melphalan. And then we have amplification of 1q21, which is seen in up to 20% of AL amyloidosis patients. Individuals with an amplification of 1q21 have a lower response rate and shorter survival if they're treated with oral melphalan. And more recently, data has come out about a lower response rate and survival in these individuals who receive daratumumab, but this data is mainly in the relapsed or refractory setting, as the rate and depth of hematological response in the Andromeda trial were not affected by amplification 1q21. And so I think the important thing as we talk about treatment is we also have to be making sure our patients are responding to therapy. And so when we talk about response to treatment, there's two things that we talk about. The first is hematological response. We define a hematological complete response as normalization of the serum free light chain levels and ratio, and a negative serum and urine IFE or immunofixation electrophoresis. A very good partial response is defined as reduction in the difference between the involved to uninvolved free light chain of less than 4 milligrams per deciliter, and a partial response as a greater than 50% reduction, again in the difference between the involved to uninvolved free light chain. Organ responses lag behind hematological responses. Organ responses can be seen at best up to 3 months after starting therapy, but oftentimes it's not seen until a year goes by. In looking at specifically heart and kidney, as that's what we talked about here today, cardiac responses are based on a reduction in the NT-proBNP as a decrease of greater than 30% compared to baseline, for example. And in kidney, it's based on a reduction in the 24-hour protein. Unfortunately, 30 to 40% of patients who do obtain a hematological complete response do not have an organ response. And so we do have certain milestones that we ideally would like to meet when we're treating individual patients. So during induction therapy, our goal is to have a hematological partial response. So again, a 50% in the difference between the involved and uninvolved free light chain after the first cycle. That increases to 2 cycles if daratumumab is not used up front. And then after 2 cycles of a dara-cyber-D combination, we would really expect to have at least a very good partial response. At any time we do not achieve these milestones, we should be thinking about alternative second-line or rescue therapies, if you will. Similarly, when we talk about monitoring of disease, if an individual has a satisfactory response, defined as a complete hematological or very good partial hematological response, plus organ response, we would continue monitoring for a deepening of organ response. If at any time we do not achieve the desired response, or we have relapsed disease, we would talk about a second line or an alternative therapy. So really, when we talk about relapsed or refractory patients with AL amyloidosis, our treatment is really based on their prior therapy. We have to take into account still their organ function, how fit they are to receive treatment, but also what have they seen previously. So the first question we'll often ask is whether or not an individual received a CD38 monoclonal antibody, such as daratumumab or isatuximab, which is an alternative CD38 monoclonal antibody. If an individual is not CD38 monoclonal antibody refractory, oftentimes we will proceed with single agent daratumumab, and there have been 2 prospective trials looking at this, or isatuximab, and there has been 1 prospective trial through the Southwest Oncology Group looking at this as well. If someone is considered to be refractory to a CD38 monoclonal antibody, such as daratumumab, then when we talk about whether or not they are bortezomib refractory. If an individual is not bortezomib refractory, we could utilize some of the induction therapies such as cyclophosphamide bortezomib dexamethasone or bortezomib melphalan dexamethasone. The doublet combination of bortezomib dexamethasone and ixazomib dexamethasone, which is an oral proteasome inhibitor, have also been evaluated with similar overall hematological response rates of 68 and 63%. If someone is refractory to bortezomib, then our next line of therapy is often an immunomodulatory agent, which could be either lenalidomide or pomalidomide, which are both oral pills that can be combined with dexamethasone. However, as we mentioned, a lot of our patients do develop relapse refractory disease or do not have organ response. So additional therapies are needed. So what's on the horizon? So these agents are currently under investigation. The first is belantamab mafodotin, which is an antibody drug conjugate targeting the B-cell maturation antigen on the plasma cell. There have been 2 very small retrospective analyses published. The first, which is shown here, included 11 patients, and they had an overall hematological response rate of 64%. And another study only had 6 patients, but had a reported hematological response rate of 83%, which is encouraging. So there's a prospective phase 2 trial, which is ongoing in Europe, and they're looking at the drug given every 6 weeks for a maximum of 8 doses. And there's a planned phase 1-2 study here in the United States that will evaluate different doses and different schedules of the drug. The next drug that's currently under investigation is venetoclax. And many of you may have heard about this drug as it is currently FDA approved in other hematological disorders such as CLL and AML. So venetoclax is a BCL2 inhibitor, and there is a retrospective, meaning looking at patients who were already treated, a study of 43 patients across 14 institutions. The dosing of venetoclax was varied, but 30 patients did have a translocation 1114. And in these patients, which is seen in graph C, the overall hematological response rate was 81%. So this has led to various studies that are currently ongoing or in the works, looking at the combination of venetoclax and dexamethasone, or venetoclax in combination with ixazomib or daratumumab. And again, these are all in patients who have an 1114 translocation. And the other agents that are currently under investigation include the anti-amyloid antibodies. So these are antibodies designed to bind to epitopes on the amyloid fibril that would lead to macrophage activation and fibril dissolution. So there are currently 2 drugs in development. One is birtamimab. This is being done through the AFFIRM-AL study, which is a phase 3 double-blind placebo-controlled trial. This is for newly diagnosed, untreated AL amyloid patients that have cardiac involvement or who are also known as Mayo Stage 4. Patients will be randomized, meaning they're randomly chosen to either receive the IV birtamimab or standard of care, which would be Dara-Cyber-D or placebo plus the standard chemotherapy. This trial is actually currently open here at Yale. The other anti-amyloid antibody that's being studied is known as CAL-101. There was a published phase 1A/B study of 27 patients, which was mainly looking at safety, but they did not see any dose-limiting toxicities, and 63% of the patients had what the authors considered to be a therapeutic response based on biomarker and/or imaging. So there are 2 ongoing phase 3 trials specifically for Mayo Stage 3A and 3B AL amyloidosis patients. And again, both of these trials are double-blind randomized phase 3 studies combining the anti-amyloid fibril CAL-101 with standard of care, which would be the combination of daratumumab, cyclophosphamide, bortezomib, and dexamethasone. Well, that's a lot of information, which is not easy to parse down. But in conclusion, we really need to individualize our amyloidosis treatments based upon an individual staging, performance status, organ involvement, and comorbidities. In addition, those with relapse or refractory disease, we need to really look about their prior therapies in choosing the next line. Our aim is for a rapid reduction in light chain burden. However, novel therapies are needed for those with relapse refractory disease and in order to improve organ responses. Therefore, clinical trials are necessary in order to advance care in this rare disease and for this patient population. So I'm happy to take questions for myself or for the group in the last 15 minutes or so.
Great. Thank you, Dr. Parker. I think Dr. Miller kindly answered a number of the questions, but I'm just seeing if Dr. Luciano is still with us. There was a question about any data connecting chronic uric acid kidney stones and renal amyloidosis.
To my knowledge, no. No.
Okay, great. Yeah, I'm not familiar with any either. Another attendee asked or shared that she is of a family of Hispanic origin, and her mother died of amyloid before ELECT2 was identified. Are there any is there any updated research on kidney involvement with ELECT2, which I know you mentioned as kind of a rare type of amyloid?
It is a rare form. No, we're just in the stages of recently being able to identify it more readily. But as far as treatment specific, as far as specific therapies targeting ELECT2, unfortunately, there's nothing out there that's close to trial at this point. It's one of those very rare forms, so therefore, although it is being studied by isolated labs, it's not to the point where it's offered on a trial basis at this point.
Great, thank you. And maybe I can answer a question and then turn it over to Dr. Parker. But one question was, what do we see for the future of AL amyloid, which I think is a great question. I think Dr. Parker did a great job of going through our current data on induction therapy, which with Dara-Cyber-D in the Andromeda trial, I think a majority of our patients are achieving quick and pretty significant hematologic responses. But I think the challenge is still the organ response, which can be quite delayed. And a number of our patients can unfortunately have complications of their organ disease despite having hematologic response. So I think I think the data on anti-amyloid fibrils are quite promising in hopes to kind of improve organ function as we're achieving hematologic response. And then hopefully some of the more novel agents that Dr. Parker mentioned can be helpful in patients with relapse refractory disease, which I think is still a really challenging population. don't know, Dr. Parker, if you have anything to add to that.
Sure. Just looking at through a few of the other questions.
Great.
One of the things about cardiac stage 4, I think the biggest thing when we talk about individuals who do have advanced stage amyloidosis, stage 4, stage 3B, is we really have to be mindful of the doses of drugs that we're giving these individuals. And that comes across in the most recently published guidelines for individuals who have stage 3B disease. And that's again based on the European Modified Mayo 2004 criteria, is what they use in the current ISA EHA guidelines. They really make a point of it's just the same treatment, the daracytoxin, daratumumab, dexamethasone, but the doses of the dexamethasone and the Velcade are being dose modified. And a lot of that has to do with fluid retention and fluid shifts, and that we can actually make some of these individuals with significant cardiac involvement symptomatically worse. And therefore, we have to be mindful of those doses and really work together with our cardiology and nephrology colleagues on supportive care and other symptom management, which both Dr. Miller and Dr. Luciano touched upon.
Great. So I think there's a question about a patient. If a patient underwent a bone marrow and autologous stem cell transplant, should they be on medications as well? Which I think is maybe referring to maintenance therapy, which is common in our patients with multiple myeloma. So in patients who have achieved a hematologic complete response or a good hematologic response post-transplant, we really don't have data, at least at this time, for continued maintenance therapy. So, we are definitely monitoring these patients very closely for worsening of their light chains or other protein amyloid markers, and also for any evidence of progressive organ disease. But if there is a good hematologic response, again, generally we are not using maintenance therapy.
I think one of the other questions is, can you reach hematological response and have worsening organ damage or new issues related to amyloidosis, such as 9 years and suddenly develop carpal tunnel? So I think the first part of that question, unfortunately, we know that individuals can achieve a hematological response and have worsening organ damage, as 30 to 40% of our patients do not have an organ response. And so some of the thoughts about why that can be is that patients can have very end-stage organ disease when they're diagnosed. As I think several of our presenters mentioned, that it can take several years sometimes, or there can be delay in diagnosis. So really these patients present with end-stage organ disease. Another area of ongoing active research is looking at the role minimal residual disease plays. And one thought is that an individual could have a hematological complete response, however, still have MRD, and that MRD is what's driving ongoing organ dysfunction. But again, an area of ongoing study.
Great. And I think another question was about autonomic nervous system involvement of amyloid leading to dysautonomia, which certainly we can see with AL amyloid and also I think with transthyretin TTR amyloid. So I think those are really the two main types we think about.
And I think we do have a question for Dr. Luciano about treating a patient who is amyloid in I'm not sure. You asked about either transplanted kidney or obtaining a kidney transplant, and they said yes. So I don't know if you want to tackle one or both.
Yeah, so I'm not sure either what that question refers to in general, but so both. So treating amyloid in a transplanted kidney. So that's complicated because the immunosuppression involved is necessary for maintaining the life of that kidney. It does happen, it does occur, but in a sense, treating the amyloid is a priority as opposed to saving the kidney. So you would treat accordingly, and if you have to modify the immunosuppression, you would do that. Unfortunately, I'm not a transplant nephrologist, so a lot of my colleagues will be treating those patients, but it does happen in transplanted kidneys. Now, as far as obtaining a transplant after you've received amyloid, that differs from center to center, transplant center to transplant center. So if you have kidney disease after amyloid, and oftentimes a patient, and Dr. Parker, this is what you kind of alluded to, the residual disease damage that can occur in specific organs. The kidney is very susceptible to that. When you have a lot of protein in the kidney and that protein is spilling, it takes well over 6 to 12 months to actually achieve a response in the kidney. And oftentimes you don't have complete response and you'll have residual proteinuria. Now, it's not because amyloid is still in the kidney in my mind. It does take a while for amyloid to clear up in the kidney, but it's because all of that amyloid and or the treatment that we're using to control the amyloid and or the diuretics that we're using or the low blood pressure that ensues does create ischemia or damage in the kidney. And that leads to scarring. And that scarring will therefore lead to permanent proteinuria. So they'll never actually clear the proteinuria and they always have a little residual protein. It's often dependent on scar. And oftentimes I've biopsied patients post-treatment response to see if there is a significant degree of scarring or some residual amyloid left over. And more often than not, it is scarring that's there and not actually amyloid itself or some other disease process secondary to treatment. Now, if that patient does develop more advanced kidney disease, it's very dependent on how long after you've had a complete response that you can then undergo a kidney transplant. And that's very dependent from center to center. Some centers are more aggressive, other centers are very conservative, and some centers don't offer transplant after the diagnosis of amyloid. So it is very dependent on which center you go to and what their specific criteria for transplantation after amyloidosis.
Great, thank you. And I think, Dr. Miller, there is also a question in the chat about recommendations for heart transplants in patients with cardiac amyloid.
So that's a complicated scenario. In general, there are heart transplants, as I said, as you saw in my talk, offered for patients with both AL and TTR amyloid, depending on the severity and the age of the patient. And the likelihood that the disease, particularly in AL, can be controlled in other comorbidities. But our center has done a number of transplants for both types of amyloid in the heart, in kind of the short answer. There was another question. I think it's one that I actually am interested in hearing from Terri or the group. The KL 101 study is focused on AL, or monoclonal antibody therapy for removal of AL protein. I'm not aware of any monoclonal antibody treatments for TTR amyloid that are in clinical trials. Are you aware of any?
I'm not.
Yeah.
Right now, the only available trials with the anti-amyloid fibrils are in AL amyloid.
Yeah.
And they're specific to the light chain fibril because they're binding to an epitope on that specific fibril. Right.
I'm not aware of it either. A couple other questions. Carpal tunnel syndrome tends to be more common in TTR amyloid very early on, and TTR amyloid that predates the diagnosis, sometimes by 5 or more years. So surgery can be very helpful. And if you have amyloid or considering having amyloid and you're having carpal tunnel surgery, let your hand surgeon know, because they can sometimes take a biopsy of the nerve sheath to see if it's there.
And I think to answer the other part of that question, to look for amyloid in the GI tract, often patients will have endoscopy or colonoscopies and have biopsies where the biopsy can be stained with Congo red to look for amyloid deposits. So that's generally how that will be diagnosed.
I think there's another question. We kind of answered that, but if an individual seeing cardiac involvement but doesn't know their type yet, just diagnosed, is it likely AL or is ATTR still a possibility?
Yeah, both are possible. It involves us looking at the imaging, looking at the bone marrow, looking at other organs that may be involved, looking in the blood, Sometimes we have to do a heart biopsy, which is not as bad as it sounds. It's a outpatient procedure done through a catheter, which patients tolerate very, very well and go home that day to figure it out. And in fact, we've had patients who've had both AL and ATTR because they're, as I mentioned, they're separate diseases. So it can be quite complicated. "20 years old, I have neuropathy." Very, yes. Reading this question about so it's interesting. Obviously, sorry you've had a complicated course of V122I, which is a common TTR mutation. That 20 years old, I'm sure you've heard this before, would be an extremely young age to be diagnosed with neuropathy from V122I or V142I TTR. So I hear all the problems and understand all the issues that you're going through, and I'm sorry to hear that. It's obviously be a complicated case that would require a lot of personalized discussion to try to figure out if there's another process going on, but it seems likely that there would be based on what we know about that particular disease.
We do have a question about whether or not this recording will be shared or accessible. I'm not sure if Eliza is able to answer that question.
Yes, this is being recorded. It will be shared to our YouTube channel, and I will be emailing the link out to all panelists and participants. So please stand by for that within the next few days.
And we may have a few outstanding questions still out there, but I think that's probably a good place to end on, as we are 3 minutes past our time at 8:30. So I just want to thank all of our panelists and speakers for joining. It's been great to hear about updates in AL amyloid.
Thank you, everyone.
Thank you.